what are the barriers to providing effective offloading therapy to DFU patients?
Well, actually, that's not a hard question to answer. The bottom line is reimbursement. It's all insurance driven. The insurance companies don't want to pay for the offloading devices. They underestimate their effectiveness. They focus so much on paying for biologics and advanced therapies, but what Wound Care 101 dictates that offloading is the key to wound healing, and they're missing that point.
There are certain ulcerations that lend themselves very well to using a shoe-based device. It's okay to not do a total contact cast on somebody with a small, shallow ulceration who's somewhat compliant and is going to pay attention to the instructions that you give them. There are people that have to drive for a living and they can't stop working.
A lot of these wounds could actually be healed without these advanced therapies if the insurance companies would only cooperate. Because the bottom line is that we're spending so much money on these advanced therapies. So if they would pay more attention to offloading, some of these biologics and advanced therapies would not be necessary in a lot of the cases.
There are also a lot of factors in offloading that come into play. The true gold standard is the knee-high non-removable device. There are numerous patients that refuse to go down that road. A lot of patients just make it extremely difficult for you to put them in things other than shoe-based devices. Some of them have real balance issues. You can't wear a cam boot or a removable cast walker when you're at fall risk.
I think the insurance companies are thinking in their head, hey, we're spending thousands, tens of thousands of dollars on these people that they could at least pay for their offloading. But in reality, it might be the cheapest thing in wound care to heal a wound. But the bottom line is that these people don't have the money. It's simple as that.
There's a serious timing issue with a lot of patients. The day you do the debridement, you need the offloading device to go on that patient that day. But if I write a prescription for a device, it'll be a week or 2 weeks before they get the device on their foot. The only thing I have the instant ability to put on a patient is either a giveaway surgical shoe that we charge $10 for, or a total contact cast. So you had to put them in a cast, which many patients would either refuse or have trouble managing with or fall. It's a very frustrating system when you don't have on your shelf, sitting right there, the exact device that you want to use, that they can walk out the door with protected. The Force insole is like that. It's a quick, easy modification. It's effective offloading, and that can be placed into a rocker surgical shoe or a cast walker, short or knee high, and give them very effective offloading device. You'd like to have these available to dispense them right there to the patient.